Hello, everybody. My name is Shirley. I'm based at University College London Hospitals in London, UK. And my colleague is
José Kersten. I'm a hematologist working in Amsterdam University Medical Centers. And one of my main focus areas of clinical research is Waldenstrom's microglobulinemia, which is also true for Shirley, I would say.
That's correct. And this is a kind of an extension of the European meeting that we had some months ago, where we both joined from Amsterdam and also from Birmingham in the UK. And there were a few extra questions which we're very happy to address today. So my answer to that would be that as things stand in the WM setting, once you start a BTK inhibitor, you are generally on it for as long as it works or as long as you tolerate it. If problems arise with tolerance, then you may have to reduce the dose. But as long as it continues to work, you would stay on that dose. There may be ways in the future of having limited duration BTK inhibitors if the treatment is combined with other agents, but this is something that is not established as yet.
Yes, I agree. So you could change the type of BTK inhibitor in case of side effects. So sometimes the other second generation BTK inhibitors have less side effects. And also, but currently still not available, at least in the Netherlands, outside clinical trials. There's a BTK inhibitor that might work in cases where the ibrutinib no longer works, which is called pirtobrutinib. I don't know if it's already available in the UK, Shirley?
Pirtobrutinib has been available in clinical trials, but there was also a named patient program, but that has been suspended. However, there are some trials of agents similar to pirtobrutinib. One is called nemtabrutinib. That trial is currently recruiting and includes WM. And there's yet other groups also called BTK degraders, so sort of allied but different mechanism of working. So there is movement in the space, I would say.
Yeah, exactly. So that's why it's important when you're a patient and a drug doesn't seem to work anymore, always ask your physician whether there are any clinical trials that might be available for your treatments. Yeah, so the question would be, is there a certain level of IgM at which we should definitely start treatment? Well, in my opinion, and I hope Shirley also agrees, there's no absolute level where we can say, okay, this is the level where you should definitely start treatment. Because symptoms may vary. Some patients will have symptoms, for example, of hyperviscosity already at lower levels of IgM, and some will have very high levels and no signs of hyperviscosity. So as long as there are no complaints, I'm not sure there is an absolute level where we should start treatment. We would, however, be more vigilant if the IgM is, higher than, for example, 60 grams per liter for those signs of hyperviscosity, and maybe monitor using eye exams. What do you think, Shirley?
Yes, I completely agree. I think I have seen many patients treated because their IgM crossed a certain threshold. And when I spoke to them, said, how were you at the time? They said, we felt fine. And I think it's really important to use treatment when it is needed, but to spare the patient before it is needed, because once you've given treatment, you can't really kind of take it back again. And treatments can be immunosuppressive. So I think that is, it's basically symptoms are the main feature, and closer monitoring if levels are a bit higher. Okay, so the question is, how long, I think, can you live with WM? And can you have periods of remission, which is when your disease is suppressed? And the answer is that people with WM typically live for many, many years, bearing in mind that a lot of people are diagnosed by chance. And those who are diagnosed with symptoms have probably had the disease for many years prior. It's just been gradually sort of building up. In terms of remission, that is something that's achieved with the use of treatment. What that refers to is that whatever disease burden you've had has been hopefully reduced. We're not often able to reduce it to absolute zero, but it can often be reduced to low enough levels to make people feel a lot better and to be able to get back quality of life and well-being. And then if we're giving chemoimmunotherapy, we would pause the treatment and monitor patients. But if you're on a continuous therapy, when you achieve that remission, we would carry the treatment on to maintain that remission.
Sorry, yeah, I don't have anything to add. I think that's a great answer. Yeah. So the question is, what are the options if you progress while on a BTK inhibitor? I think that really depends on the situation. Is it necessary at that time to start a new treatment already immediately? What were the treatments prior to the BTK inhibitor? Because there are, of course, other options in terms of immunochemotherapy or proteasome inhibitors. As we discussed earlier, we have new BTK inhibitors and BTK degraders that might work also when the Waldenstrom doesn't respond to the ibrutinib anymore. And yeah, in the future, we hopefully will have new options that are currently still in clinical trials, such as venetoclax and immunotherapy with antibodies, bispecific antibodies that bind both the Waldenstrom cell and the T cells, but that's all still in clinical trials. So it's a long answer to a short question, but it really depends on the situation, I would say.
Yeah, I would agree, absolutely. There are things available for after BTKIs. We've talked about alternative BTKIs as well, but there is also, José mentioned venetoclax. There are new agents to target the same target called BCL2, and some trials are soon to open on that. Very promising agents, and again, getting more targeted because of biological developments in the field. So I think, watch this space. I mean, things are happening all the time. So to be honest, the most common pain in joints is due to wear and tear and arthritis, which affect more and more of us as we get older because our joints wear out. However, there are some inflammatory conditions that can affect joints due to perhaps imbalances in the immune system. So sort of well-known ones are things like rheumatoid arthritis, etc. These are diseases that are treated by rheumatologists, sometimes with immunosuppressive therapies. And those conditions are usually underscored by some positive blood test results and certain characteristic features in the joints when you image them and behavior of the pain, etc., and swelling. Cryoglobulinemia is worthy of note as a complication of WM. It is when the IgM sort of sticks to itself in areas of coolness in the body, and it can cause deposition of sort of immune proteins in joints. I wouldn't say it's a particularly common event in WM. Cryoglobulin does cause other features in WM, perhaps nerve damage and maybe kidney damage. But certainly if you have joint symptoms, I think it's worth seeing your doctor and finding out the character of the joint problem and then having relevant tests because it's not a common direct feature of WM.
Yes, I agree. It is described in patients with cryoglobulinemia, but I think you should always look for other causes, like Shirley said, like arthrosis, arthritis, and rule those out as well. So can WM make diabetes more likely? I would say it's not directly related to Waldenstrom's macroglobulinemia, but if a patient is treated, for example, with a steroid-containing regimen, you could have steroid-induced diabetes, which can also be reversible once the treatment with steroids is stopped or interrupted. It might require temporary treatment, but I'm not aware of any data that Waldenstrom's is directly related to diabetes. And of course, diabetes type 2 is a condition that is quite prevalent in the, I would say, adult population.
Yeah, I agree and have nothing to add to that. So that's a great question, and one that we ask very often in our clinics because it certainly can do, but because someone has an IgM paraprotein and a nerve problem, neuropathy, it doesn't necessarily mean they are connected. So if someone has both, it's very important for that person to be very clear history to be taken from the patient about the nature of the nerve symptoms, the distribution, whether it's starting in the feet and going upwards, whether it's in both feet, or is it just randomly distributed. So really the history is very important. Then certain supplementary tests can be done to measure whether the nerves are actually showing signs of electrical impairment. And then the correlation needs to happen with the IgM. There are certain proteins on nerve insulation that can be affected by IgM, which of course is an antibody. And this is some, for example, MAG, myelin-associated glycoprotein. So if that is the next thing, one needs to perhaps measure things like anti-MAG antibodies. There are a few others one can measure as well. But again, not to jump to conclusions that just because an anti-MAG is present, that it is causing neuropathy. There are many other much more common causes of neuropathy, such as diabetes and certain other medications, etc. So it really does take very due diligence, I would say, to first of all establish A, whether there's nerve damage, B, the nature of that nerve damage, and then C, whether it could be related to the IgM. And if so, then yes, consideration of treatment.
Yes, I agree. And I think it's very important for this, especially that there's a close collaboration between the hematologist and the neurologist. Like you do also in your center, a joint clinic for those patients, because very often, it's quite for us quite hard to really understand the neuropathy, and the neurologist can really help to determine the severity and also the response to therapy, which is also quite difficult to monitor. I think there's still a lot to be learned there. So are patients who are treated for the first time eligible for a clinical trial? I would say yes, if there is a good clinical trial where there is a very promising new therapy or combination regimen, they could be eligible for this. Of course, this has to be a very promising treatment because we have good standard treatments. It really depends on the design of the trial. And I think in the UK, there's the Rainbow study. Shirley, maybe you can discuss this study.
Absolutely. I think you make a really good point, Maria-José, that we do know that chemoimmunotherapy is extremely effective in most people with WM. So if we're going to do upfront trials, it has to be at least as good, if not better. So we do actually have a trial in the UK called the Rainbow study, which looked at a rather commonly used regimen called dexamethasone, rituximab, and cyclophosphamide, which is so-called randomized against a combination of ibrutinib and rituximab. So we're looking at a regimen which is given for 4 months or so, 6 cycles, versus one that is given indefinitely, really, as long as it works. So that's the main distinction between these two treatments. But what we don't yet know, other than some early indications, that if you combine rituximab with ibrutinib, you may well gain good responses, which could last a long time. But we do know, for example, that if people can develop side effects from ibrutinib and similar drugs, and they can also develop mutations that cause resistance to ibrutinib. So I guess this study in particular is looking at whether combining ibrutinib with rituximab will help overcome that difficulty. But to be honest with you, until trials report, we don't know the answer to them. So it's really important to discuss very carefully and weigh up what you feel you want to do at frontline, especially, because that's a very, very crucial decision which has impact for you sort of in the short term and in the longer term. Ooh, that is, well, I frown a little bit because COVID questions are always, raise some discomfort because we're still learning about it. I think the general answer would be not to discontinue because, first of all, when you're on BTK inhibitors, we're thinking about it quite broadly, there's a slight increased risk of bruising and bleeding, but a vaccine is unlikely to cause a significant problem. You get an intramuscular shot. It's more to do with immunosuppression, whether you're going to dampen the response by continuing to be on a BTK inhibitor whilst you're having the vaccine. Now, I'll be very interested to hear what Maria-José thinks. We don't stop it for that because I don't think anyone knows how long one should stop it and whether stopping it produces the relief from immunosuppression that you need in order to make a vaccine effective. That's my feeling. I don't know what you think, Maria-José.
Yeah, I agree. So there is evidence from several groups, including our group, that the response to COVID vaccination is less in terms of antibody response in patients who are on a BTK inhibitor, either for CLL or other diseases. And I think in Australia they did a very small trial, but it was only, I think, about 9 patients who were willing to stop their BTK inhibitor for Waldenstrom for a few days to give the vaccination. And I think they saw a bit better antibody response, but after some in the first instance, but later the difference sort of disappeared when the antibody response again was worse when they recommenced their BTK inhibitor. So I think at the moment we don't advise to stop the BTK inhibitor, but we do advise to get the booster vaccinations if necessary, because more vaccinations can help to increase the immune response. And we also still advise patients to be careful, when visiting others who have COVID or might be infected.
Yeah.
And the same is also true for patients who are treated with rituximab, because that also diminishes the antibody response. I would say that cancer-related fatigue is common in many malignancies, also in patients with solid tumors, and for sure in patients with other hematologic malignancies. We do see it very often in patients with Waldenstrom's. I would say 70-80% of the patients have more or less severe fatigue. So it's really a clinical problem. It can be caused by several parts of the disease. For example, patients can have low hemoglobin levels, anemia, which can have various causes in the context of Waldenstrom's, but it can also be even also with a normal hemoglobin level. So I always say, yeah, we don't just look at the numbers, because there's more than just the hemoglobin level. And yeah, fatigue, I would say, is definitely a very frequently occurring topic also in our clinics. Very difficult also to really do something about it. Shirley, what are your thoughts?
I think fatigue is very complex. It's got factors that contribute. I think in WM, there's the anemia, as Maria-José mentions. I also feel that because it's a sort of inflammatory condition that does just chronically use up people's energy in the background. There is something that sometimes helps, and that is if you identify a low iron level, then, because in Waldenstrom's, the utilization of iron, even if you have iron in your diet, can be impaired. So you can sometimes improve levels of fatigue by giving iron replacement, preferably an infusion of iron. Now, this may or may not work, but it's worth doing. But other than that, there is also the psychological burden of having it. And many people, even without Waldenstrom's, are always very fit. So it takes quite a lot of working at it. I think a good way forward is to actually take on some regular, simple exercise, actually, like walking and so forth. It has many, many benefits. Not overdoing it, but just trying to keep supple and mobile. It can work. So autologous transplantation, that's the question. That is when you have stem cells from yourself to rescue your bone marrow from high-dose chemotherapy. And the rationale for giving high-dose chemotherapy is to suppress the disease in the bone marrow or elsewhere, and then return the stem cells so that the bone marrow can be repopulated. I think oftentimes, but it's not something that one has to use often, because WM is inherently pretty sensitive to chemotherapy, number one. Number two, we have a lot of other options available to us that work in different ways to chemotherapy. So I think some years ago, we would do this in some patients because all we had was chemotherapy, and we then had to sometimes escalate. I think it is something that could have a role in perhaps in some relapsed patients. It's really not clear cut, especially that now that there are more options available, which are actually increasing all the time. And I know, Maria-José mentioned cellular therapies and other sort of molecules. So yeah, what are your views, Maria-José?
Yes, so as you said, we quite rarely do it. So you might consider it in patients who are very young and fit and have a short response to immunochemotherapy. Because also other therapies like ibrutinib, you don't want to give it for 20 years, for example. So in those patients, we might consider it. Also in patients with amyloidosis secondary to Waldenstrom's, we might consider it to get with the high-dose chemotherapy a really deep remission of the Waldenstrom's to be able to get rid of the amyloid. But yeah, it's not something we use very often because of the side effects.